bit about the oral manifestations of diabetes and dental management of these kind of patients. Next. So, as we all know, diabetes is associated with a high morbidity due to a broad range of complications that can be divided into acute and chronic complications. Chronic complications are characterized by damage to the vasculature and are grouped into micro and macrovascular diseases. Since oral complications are most likely the result of long-term effects of diabetes, they can be considered as chronic complications. The large majority of studies into oral complications still approach patients with diabetes from the limited perspective of elevated blood glucose levels. However, we know that there are many other pathogenic mechanisms that are involved in the development and progression of chronic diabetic complications. Next, please. As we can see here in this figure, hyperglycemia is the clinical characteristic that is used to define a patient with diabetes. However, like I said before, several other pathogenic mechanisms that characterize diabetes are recognized. As we can see here, insulin resistant, dyslipidemia, immune dysfunction, and hypertension. As a result, we can have microvascular complications such as retinopathy, nephropathy, neuropathy, and diabetic foot. And among the macrovascular complications, we can find coronary artery disease, cerebrovascular disease, and peripheral artery disease. Finally, possible oral complications are, we can see at the bottom of the figure, periodontitis, caries, dry mouth, oral mucosal lesions, oral cancer, taste disturbances, and other oral complications. We are going to see that all of the, metabolic disturbances, like I mentioned, hyperglycemia, insulin resistant, dyslipidemia, immune dysfunction, and hypertension might play a significant role and in the other chronic complications of diabetes, in the oral complications. Next, please. So here we can see some oral complications of diabetes. I'm gonna try to use the pointer. I think, can you see the light there?
No.
No, not really. Okay, it's okay. It's okay. So for example, on picture 1A and 1B, 1A shows the clinical aspect of periodontitis with the corresponding radiograph in 1B. 2A and 2B, 2A clinical view of caries, 2B the corresponding radiograph of a deep carious lesion. On picture 3, we can see the typical feature tone that is very characteristic of a patient with hyposalivation. Picture 4, oral candidiasis in the hard palate. Picture 5A and 5B. 5A shows leukoplakia, 5B and oral cancer. In the picture 6A and 6B, 6A shows the characteristic fistula due to we call a periapical abscess, which is showed in the radiograph in picture 6B, I'm sorry. Pictures 7A and 7B show the temporomandibular disorders, usually where on 7A, usually where the patient feels pain, and 7B, limited mouth opening. And finally, in picture 8A and 8B is called a condition that we call peri-implantitis, which is a periodontitis around a dental implant. Next, please. So we're going to start with periodontal diseases. Periodontal diseases can be subdivided into gingivitis, as we can see on the right hand, which is a reversible inflammation of the gum around the teeth without loss of support, and periodontitis, which has the clinical appearance of gingivitis, but also shows irreversible destruction of the supporting structures around the teeth. So as you can see there in the diagram, the supporting structure of the teeth are a cementum, periodontal ligament, and alveolar bone. Well, the destruction of this supporting structure is that they usually lead to alveolar bone resorption and tooth loss. Between 30 to 50% of adults suffer from any form of periodontitis, including the mild and moderate variant, while the prevalence of severe periodontitis in adults is estimated to be approximately between 9 to 11%. Next. So several types of periodontitis have been described, as we can see here. So we can mention aggressive or chronic periodontitis, necrotizing gingivitis and periodontitis, and finally periodontal abscesses. Recently, a new classification and case definition has been introduced. So we have periapical periodontitis, which is a specific type of periodontitis affecting the periodontum around the apex of the tooth, and peri-implantitis, like I said before, a chronic inflammation affecting the tissues around dental implants. Periodontal disease is the result of an atypical inflammatory host response to the biofilm that resides around the teeth in some susceptible subjects, and initial gingivitis can progress into chronic periodontitis. Several risk factors that might influence the susceptibility for periodontitis have been established in literature, clustered in 5 categories. So we have the environment, which is usually the subgingival microbiome, genetics, systemic disease such as diabetes, and a patient with any kind of immunosuppressed condition, lifestyle such as oral hygiene, smoking, diet, and tooth-related factors, for example, iatrogenic causes or occlusal problems. In chronic periodontitis, irreversible loss of supporting tissue surrounding the teeth result in deep periodontal pockets and attachment loss, which are commonly used to define a patient with periodontitis. This impairing process eventually causes loosening of the teeth, and ultimately, when the treatment is not initiated, result in tooth loss. Next. Okay, how about the relationship with this condition, between this condition and diabetes? Periodontal disease has been linked to diabetes for a long time, since Lowe suggested to consider periodontal disease as the sixth complication of diabetes. In 1993, periodontitis became the most researched oral complication of diabetes. This condition is known to be a complication of both types of diabetes, type 1, type 2. According to several studies, diabetes is considered as a risk factor for the development, progression, and severity of periodontitis. An important source of evidence is the research conducted with the Pima Indians in the 90s. This is a population with one of the highest type 2 diabetes prevalence in the world. Indeed, diabetic subjects within this population displays an increased prevalence of periodontal disease. More importantly, analysis of longitudinal data from this population also showed that the incidence of periodontitis in patients with poorly controlled diabetes was more than twice as high compared to subjects with well-controlled or no diabetes. The risk for alveolar bone loss was higher in the poorly controlled diabetes group, as well as the severity of disease progression. Next. So the most widespread hypothesis state that diabetes might affect periodontal tissue in a way similar to how it affects retinal, neural, and renal tissue. That is through vascular damage. The same 5 pathological mechanisms that I mentioned before, hyperglycemia, hypertension, dyslipidemia, immune dysfunction, and insulin resistance, that cause the well-known systemic condition of diabetes could play a significant role in the pathogenesis of periodontal diseases. Next. As I mentioned earlier, if we talk about the first mechanism, hyperglycemia, poor glycemic control increases the risk for periodontitis in patients with diabetes. And improvement in HbA1c levels reduces periodontal inflammation. Next, there's evidence that the underlying upstream mechanism, oxidative stress, affects periodontal health as any of the other organs and tissues in the body. Low antioxidant levels are often interpreted as indicator for oxidative stress, and several studies had found decreased levels of antioxidants in serum, periodontal tissues, and saliva of patients with diabetes and periodontitis, compared to subjects without diabetes. Next, please. Of the downstream effect of hyperglycemia that might play a role in the pathogenesis of periodontal diseases, advanced glycosylation end products and receptors for ages had been studied the most. Periodontitis is characterized by destruction of connective tissue, both in the gingiva and periodontal ligament, suggesting similar pathogenic pathways with damage of connective tissue in joints via H accumulation. Ages and rage are both increased in gingival tissue and saliva of patients with type 1 and type 2 diabetes. The mechanism by which ages are involved in periodontal tissue destruction are probably the same and is in the well-known complication of diabetes. So as we can see here, enhanced inflammation, impaired wound repair, increased oxidative stress. This results in increased gingival connective tissue and periodontal ligament destruction and alveolar bone resorption. Next, regarding the second mechanism mentioned, which is insulin resistant, some studies have established the potential for periodontal infections to contribute to insulin resistance and the development of type 2 diabetes. One specific causal pathway linking infections and type 2 diabetes risk is chronically elevated systemic inflammation. Systemic inflammation is known to be elevated among participants with periodontal infections and also has been shown to predict the progression of insulin resistance as well as the development of type 2 diabetes. Other studies, mainly animal studies, have hypothesized that insulin resistance negatively influences periodontal health, but longitudinal studies with human subjects are necessary to confirm this hypothesis. Next. So regarding dyslipidemia, several studies have showed that the lipid profile typical for patients with diabetes, which are low levels of HDL, high levels of triglycerides, and a slightly increased LDL, has been associated with deterioration of periodontal health, characterized by increased periodontal attachment loss, pocket depth, and bleeding gums. Next. The mechanism by which this lipidemia contributes to periodontitis is not fully understood, and more studies to establish a causal relationship are needed. However, it is hypothesized that similar to hyperglycemia, this lipidemia stimulates a pro-inflammatory state and thereby increasing the susceptibility for periodontitis. Furthermore, it is thought that besides glucose, lipids can also act as a source for reactive oxygen species in gingiva through lipid peroxidation. Patients with diabetes and dyslipidemia have shown increased level of markers for lipid peroxidation. And when I was trying, to find more information, recent information about this condition, I found a very interesting fact, and this is like a new insight, is the beneficial effect of statin therapy on periodontal treatment outcome in patients without diabetes. But the researchers, the authors, found that it's not necessarily caused by statins' lipid lowering effect. It could be the result of other features of statins, such as antioxidant or anti-inflammatory effect. But I think I found really interesting. Next, so regarding hypertension, it is hypothesized that hypertension is associated with periodontal disease, although the majority of studies interpret this relationship as periodontitis being a risk factor for hypertension through inflammation. This hypothesis is mainly based on findings that periodontal therapy is beneficial for systolic and diastolic blood pressure. However, longitudinal research in the opposite direction is lacking. Hypertension might very well be a risk factor for developing periodontitis, as it is for other diabetic complications. Next. Finally, in terms of immune dysfunction, periodontitis is a chronic disease characterized by an abnormal inflammatory host response to the biofilm. However, in patients with diabetes, this pro-inflammatory state seems to be even more exaggerated. Polymorphonuclear neutrophils, but also monocytes and macrophages, produce more inflammatory mediators and ROS, which could contribute to tissue destruction in periodontal diseases. And next, additionally, patients with diabetes showed increased levels of inflammatory cytokines in gingival crevicular fluid and gingival tissue compared to healthy subjects. Tumor necrosis factor alpha also contributes to periodontal tissue destruction by enhancing the inflammatory response and activating osteoclasts responsible for bone resorption. In the case of periodontitis, especially the PMN, response seems to be impaired, characterized by reduced chemotaxis of these cells, by these cells. This might cause opportunistic pathogen in the biofilm to persist over time, thereby causing the abnormal inflammation to retain, which enhances the progression of periodontitis. Next, another common complication and another, caries and, periodontal diseases, gum diseases are the most common pathologies that we can see in the general population. Well, so regarding caries, the etiology of dental caries is a dynamic process that involves a susceptible tooth, cariogenic bacteria in dental film, specifically Streptococcus mutans and Lactobacillus, and the detrimental effect of cariogenic carbohydrates. Modifying factors also include the absence of fluoride, serostomia, and inadequate oral hygiene. The demineralization process during an acid attack and subsequent remineralization by saliva and fluoride happens continuously throughout the day. The chart on the right hand is a guide to assess a patient's risk factors for the development of dental caries. Next. So regarding the epidemiology of this condition in patients with diabetes, several literature reviews that discuss the association between diabetes and dental caries point to the lack of solid evidence for a clear correlation. There's limited research available on the epidemiology of caries and type 2 diabetes. Some papers found an increased prevalence of dental caries, which was supported by investigation using diabetic animal models. On the contrary, several studies did not find a significant association between type 2 diabetes and caries. And as a matter of fact, some studies even had found decreased incidence of caries in patients with diabetes. So this could be explained that, like as we know, lifestyle adjustment and losing weight are important in diabetes care, especially for type 2 diabetes. Restrictions of carbohydrate intake is a crucial part of the strategy to lose weight, which might reduce the risk for developing dental caries in diabetic patients. Next. So regarding the pathogenesis, in contrast to periodontal diseases, less is known about biologic explanation for the possible association between diabetes and dental caries. It is important to know several complicating factors. First, adult and elderly individuals with diabetes often suffer from periodontitis, as discussed before. This is associated with gingival recession, when the gums are receding, which exposes dental root surfaces that then become susceptible to root caries. So in the crown of the tooth, we have the enamel. In the root, we have cementum. Cementum is less mineralized than enamel. So when the root of the tooth is exposed, that part of the tooth is more susceptible to the attack of the acid of the bacteria. Patients with diabetes also often suffer from decreased salivary flow rates and altered saliva composition. Since saliva acts as a buffer against the acidic byproducts from the bacterial fermentation of carbohydrates, a change in quantity or composition of saliva could therefore influence the protective function against dental caries. Next, another condition is dry mouth, serostomia, hyposalivation. So usually two distinct phenomena are referred to dry mouth. So we have the first one, which is the objective measurement of reduced salivary flow rate, called hyposalivation or salivary gland hypofunction. The second condition, often referred to as dry mouth, is serostomia, which is the subjective experience by a patient of dry mouth. The experience of a dry mouth is one of the most frequently mentioned oral complaints by patients with diabetes. In a way, this is not surprising, considering the fact that the population with type 2 diabetes generally consists of relatively older individuals. As we know now, the prevalence of serostomia and hyposalivation increases with age. Also, many patients with diabetes suffer from one or more complications and or comorbidities. for which they possibly receive different kind of medications that increases the risk for oral dryness. So we have anticholinergic, antihypertensive, tricyclic antidepressants, that all of those, we know that they can cause dryness in the mouth. Although many studies report an increased prevalence of serostomia and a decreased salivary flow rate in patients with diabetes, the mechanisms underlying these observations remain unclear. Secretion of saliva by the parotid gland, which is the major salivary gland, is regulated by the autonomic nervous system, which led to the hypothesis that diabetic neuropathy might somehow be involved in the development of dry mouth experience. There are few studies that actually observe structural changes in the salivary glands of patients with diabetes, in particular in the parotid glands. Vacuolization of acini in the parotid gland has been observed, which indicated an early form of degeneration. Another study showed atrophy of the acini and ducts and adipose infiltration in the stroma of the gland. In general, patients with poor glycemic control present significantly lower salivary flow rate and higher prevalence of serostomia compared to subjects with well-controlled diabetes. Next. Okay, now, oral mucosal lesions include multiple oral lesions, but the large majority of studies investigating the association between diabetes and oral mucosal lesions focus on Candida-related lesions. Candida albicans, as the most common species, can be found on the skin and all the mucosal surfaces. It exists in healthy individuals as a commensal organism, but causes opportunistic infections in susceptible patients, such as patients with HIV/AIDS, person using immunosuppressive drugs, an individual with poorly controlled diabetes. Oral candidiasis, as we can see in the picture, the first picture on the left hand, is a pseudomembranous candidiasis. The next picture is a medium rhomboid glossitis. The bottom picture on the left hand shows a patient with angular cheilitis, and the last picture on the right hand is denture stomatitis. Assessment of the association between diabetes and Candida-related lesions is hampered by the complexity of the lesions, variation in study population, and interaction with other local risk factors. Some cross-sectional studies investigating the previously mentioned candidal manifestation showed a higher prevalence, definitely, of median rhomboid glossitis, denture stomatitis, and angular cheilitis in patients with type 1 and type 2 diabetes compared to healthy controls. Next, and due to the time, I am going to touch briefly these three other complications, which is oral cancer, temporomandibular disorders, and burning mouth syndrome. Okay, so regarding oral cancer, epidemiologic research seems to indicate an increased prevalence of oral premalignant lesions, such as oral leukoplakia. Oral leukoplakia is the most prevalent premalignant lesion, and oral cancer in patients with type 1 and type 2 diabetes. Besides its effect on cancer incidence, diabetes also negatively affects the prognosis of patients with oral squamous cell carcinoma, which is the most prevalent oral cancer. There's a lack of research into possible pathogenic pathways that explain the association between diabetes and oral cancer. Hyperglycemia seems to play a significant role for increased risk of oral cancer in patients with diabetes. but there's only limited evidence about this finding. For instance, some studies have shown that elevated levels of HbA1c have been associated with an increased risk of oral leukoplakia, which is, like I said, a premalignant oral mucosal lesion. In terms of the temporomandibular disorders is an umbrella term that comprises several conditions affecting the temporomandibular region. The principal clinical feature of temporomandibular disorder is pain during mastication, often accompanied by joint sounds and or limited mouth opening. Patients with diabetes are susceptible for joint disorders, primarily through the damaging effect of ages on connective tissue. From that perspective, the temporomandibular joint could be affected as well. Interestingly, some investigators have also found that within the diabetic group, peripheral diabetic neuropathy has been an independent risk factor for temporomandibular dysfunction. Finally, burning mouth syndrome BMS is a chronic pain syndrome. Usually two types are distinguished. So we have primary BMS, if there are no underlying diseases that can explain the complaints, and secondary BMS, when there's an oral or systemic disorder that could explain the condition. BMS rarely affect individuals younger than 30, and is more prevalent definitely in females. Apparently, there's a significant overlap with other oral conditions and complaints that are associated with diabetes as well. This overlap, together with a lack of uniform definition of BMS, complicates epidemiologic research into the association with diabetes. Some studies have reported increased prevalence of BMS in patients with diabetes compared to healthy subjects, while others have not found any difference in prevalence of BMS. Next. Okay, now, in terms of the oral care for the diabetic patient, we have the group that has low risk for dental treatment. This is the well-controlled individual who can undergo all routine dental procedures without special precautions. And here we can see the following characteristics for this group, like a fasting blood glucose between 70 to 200 milligrams per deciliter, no other complications, blood pressure, you know, in the normal range, functional capacity, good, and HbA1c less than 7%. So if extensive surgery is needed for these individuals, consult with patient's physician concerning dietary needs during post-operative period. I think is needed. Next. For the moderate risk for dental treatment, so we have patients with reasonable metabolic control with no recent history of ketoacidosis or hypoglycemia, fasting blood glucose between 200 and 300 milligrams per deciliter, HbA1c between 7 to 9%, and antibiotics are usually indicated post-surgically. Next. And then finally, we have the high risk for a group for dental treatment. So here we have a fasting blood glucose greater than 230 milligrams per deciliter, HbA1c greater than 9%. If patient is symptomatic, seek immediate referral. If patient is asymptomatic, request a routine referral. So here we can provide appropriate emergency care only, manage infections aggressively by incision and drainage, extraction, tooth extraction, pulpotomy, which is a conservative treatment, is usually the first step for a root canal therapy, warm rinses, and antibiotics. Patients who are receiving insulin usually require additional insulin, which should be prescribed by their physician. Next. So patients who should be referred to their physician for evaluation and establish the patient status, who have not seen their physician for a long time, patients who have frequent episodes of insulin shock, and patients who report signs and symptoms of diabetes. Next. To prevent insulin shock during dental appointment in patients who are being treated with insulin, the patient should take the usual insulin dosage, eat normal meals before the appointment, monitor symptoms of an insulin reaction, and have available a source of sugar such as orange juice, cake, icing, or non-diet soft drink. Next. Other treatment guidelines that we usually follow when we are providing oral care for patients with diabetes: avoid use of aspirin and other NSAIDs in patients particularly taking sulfonylureas, because this can worsen hyperglycemia. Early morning appointments, routine and periodic follow-up evaluation is advised for patients with diabetes. Inspect for oral lesions as a way to monitor for disease progression. Remember that we already discussed that specifically periodontal disease are, closely related, especially with the progression of diabetes. No anesthesia issues if diabetes is well controlled. For diabetic patient with concurrent hypertension or history of recent myocardial infarction or with cardiac arrhythmias, dose of epinephrine should be limited to no more than 2 cartridges of 1 to 100,000 epinephrine. Next. Okay. I'm sorry, I try, to cover everything in this time, but I mean, definitely there are much more, and unfortunately, because of the time, we cannot discuss, or I cannot give you more information specifically about other complications on diabetic patients.
Thank you so much, Dr. Buguano. That was really incredible, and seeing that overlap between dentistry and diabetes and endocrine in general is so great. So we truly appreciate you presenting that today, and it was perfect. The timing wise was perfect, so no worries at all. I wanted to ask everyone in the group, did anyone have any questions or comments or thoughts that you wanted to ask Dr. Buguano?
This is Dr. Paliwal. Do you recommend any kind of oral rinse for diabetic people to prevent dental complications, like routinely?
Yeah, routinely, yes, we can say yes. Okay, especially, the thing is with the most of the commercial oral rinses, they have alcohol. I know that there's several now alcohol free, but it's basically oral hygiene instructions that we can recommend to diabetic patients, because as we see, the disturbances between, if we try to avoid the balance between the bacteria, the diet, and the biofilm that is deposited in the teeth, I think it's extremely important a well control of the plaque, which is usually by correct toothbrushing. And of course, sometimes we can recommend some kind of oral rinses. I think it is depending on each case, but we can recommend some oral rinses.
Oh,
Mitra, you were on mute.
That is so bad. I do that time to time, but I'm usually not that bad about it. I apologize, everyone.
Oh, okay. I'm sorry.
No.
Dr. Whitaker, would you like to add something about that question?
Not much. I guess, how often would you use Paradex? Because you could treat a little bit of Candidiasis and the perio condition, right? Is that right, Dr. Pagano?
Yes, yes, yes. I'm sorry. Yeah. Mhm.
And
Dr. Bueno, I have a question. I think that was a wonderful presentation. Thank you. In my own clinic, I feel as though one of the major issues with my patients that have diabetes is they have a difficult time getting into dental clinics. And it's too costly. I have a really high population of, Medicaid, Medicare patients who really struggle to see their dentist routinely. And so they often use the emergency room for, abscesses or severe issues. Do you know of any solution to that? I know that's magic.
No, yeah.
I feel like if
No,
you
no,
have any magic I could use, I'd appreciate it.
Yeah, the reason why I'm laughing because, it's the same problem that we have as an oral care providers. I mean, of course, we would like to cover as many as patients as we can, but well, what we usually do, I mean, for example, I am a faculty in urgent care clinic here in our school. So what we usually, try to tell the patient that besides, resolving the specific urgent problem, we usually try to talk with them and then try to get comprehensive treatment, comprehensive evaluation, and then comprehensive treatment. In terms of the insurances and Medicaid and can you add something, Dr. Whitaker, about that? Because I know you know more than me about that part.
well, yeah, I'm glad you brought that up. They did pass some legislation last year, and starting January 1st of this year, Medicaid patients now have $1,000 to use towards dental care. And that's not necessarily even urgent care. So that's in addition to urgent care. So they could have, some emergency treatment done and then follow up with, a few other things if they needed a new set of dentures or what have you. So anyway, we do see those patients here. Like Dr. Pagano was saying, our student fees are going to be probably a third or less of what somebody would see on the outside. And the only drawback to that is it takes a long time to get through the system. But anyway, that would be a great thing to do. And like you said, they come through on an emergent basis. We try to, get them to come through the student clinic and, try to determine the rest of their needs. And the other thing I might say is Dr. Pagano is really a great resource. He's our first oral medicine practitioner in the state. And he treats all types of, oral infectious disease and all these things he's been talking about. And he has a practice here in the building and is available. And please take advantage of his expertise. He trained at Penn, and that's kind of the place to go for oral medicine. So anyway, we're certainly glad to have him here and speak with y'all.
Thank you, Dr. Whitaker. And I am convinced, that a multidisciplinary approach for this patient is wonderful, and I am glad to have the opportunity, and I am glad, to collaborate with you guys, with your patients, and if we can, of course, approach these patients in a multicultural, in a multi-way. That could be really, really, really good, especially for the patients.
Dr. G, I think you're muted as well.
Oh, sorry about that. I'm so glad you brought that up, Dr. Bueno. We're trying really hard here to start a diabetes kind of institute so that we can have more of a multidisciplinary approach and have more connectivity between all the different disciplines of medicine, because I think that would really help the care of our really high patient population of diabetes within the state. And maybe even have something someday, hopefully of multiple providers in one area where it's a one-stop shop. You come in for an appointment, you see your dentist, your podiatrist, the diabetes, provider, and hopefully that would make things a little bit easier. And even if it's not in person, it sounds like things are really going toward telemedicine too. So that, you know, hopefully opening up the doors for patients with diabetes and making life easier, whether that is one-stop shop and coming into clinic, or whether it's what we're doing today. And we have a collaboration of multiple different doctors addressing one patient at a time, which would be phenomenal. That's more magic that I'm hoping for.
And you know, sometimes, and I do believe that, for example, we have to educate our population, sometimes very simple steps, such as, you know, some educational sessions with our patients can prevent a lot of different things. So I think that could be also a really important thing.
Absolutely.
Thank you all so much. Does anyone have any other comments or questions they wanted to ask the group or Dr. Bugueno specifically? Feel free to unmute or chat in.
So you muted everybody? That's okay.
Group setting, actually.
Okay. No, that's fine. Okay, that's fine.
Yeah, unfortunately, I'm not allowed to unmute folks. So if there's any difficulty unmuting, it's, I think, for privacy standards.
No, yeah, of course.
And Dr. Bugueno, I wanted to let you know, I got a chat in too privately saying that they learned so much from you today and lots of great information. So they were thanking you about your presentation.
Thank you.
Today.
No, thank you, everybody.
All right, well, if there are no further questions, as always, feel free to shoot me an email. I'll make sure to have them addressed. I can send them to Dr. Bugueno if there are any questions after the fact. Big thank you, Dr. Bugueno, for the awesome didactic today. And we're so thrilled about this collaboration. It's just so great to see it come to fruition. So we truly thank you for your time. And
I didn't hear the claps. Oh, no, no. That's right. That's right. Okay.
We do this a lot. We did this in the meetings.
Yep.
Thank you.
Visual clap.
Okay.
But thank you.
Thank you.
Thank you all very much. Thank you, Dr. Bugueno.
Okay.
Appreciate it.
Thank you. Have a great day.
You too.
The
Bye
only
bye.
announcement I do have that I wanted to say before we part ways, our next session will be on March 10th, and Cherie Bryan is going to discuss progressive nature of type 2 diabetes. So just keep an eye out for that reminder, and we'll see you guys next time. Thank you, guys.
Thank you.
Bye.
Thank you. Bye-bye.